Good morning and welcome to the community practice on autism spectrum disorder and other developmental disabilities. My name is Tim Markle. I'm one of the co-chairs for the COP ASD DD, and we are excited today to have a series of speakers and presenters from the Waisman Center. We're going to be talking about early identification and autism. And so without further ado, I'm going to turn this over to Lily Wagner, and she can introduce herself, and let's just get going. Thank you, Lily, so much for being here.
Thanks so much, guys. I'm so happy to be here with you. Let me hold on and make sure I'm sharing the right screen. Hold on. Let's see. 1 second.
Yep. For some reason, we have that
Uh,
floating black bar.
That's always
I
fun.
know. I love it when the floating black bar joins us.
I know. Hold on 1 second. I had it so great for a second, and now I've all right. Let's see if this will work. Can you see the screen? My slides are
So you're sharing the screen with the slides. Now we have the correct view. So
okay. So
everything looks
see
good,
the full
Lily.
screen?
Yes.
Okay, great. Okay. Hi everyone. My name is Lily Wagner. Like Tim said, I am a Southerner, new to Madison, Wisconsin. So this is my first big snow here. So it's thrilling. Um, and I am the director of the Autism and Developmental Disabilities Clinic at the Waisman Center, and also a researcher. And my research centers upon early identification and access to early intervention services, specifically for children who face disparities in access to those services. So was very happy to get the chance to talk to you all today a little bit about the little kiddos. And there's so much innovative work that's happening in this area right now. It's hard to kind of decide what to focus on. So I'm just going to today speak a little bit about the importance of early identification, kind of our existing systems for it, what we're looking for with young children who are suspected of autism, and some of the barriers that we're experiencing to early identification, and touch very briefly upon some of the ways that we at the A&DD clinic are trying to make sure kids get access to services as quickly as they can. And then I have my wonderful colleagues here today with me, Erin, Thomson, and Kellie Haugen. And they're going to speak with you a lot more about the fun stuff. So actually working with children and how to get them navigated access to the services that they need. I see that some comments are coming in. I can't check them while I'm doing this. So Tim, just interrupt me and let me
No,
know if there's
no
any.
worries, Lily. That's why I'm here.
Okay, perfect.
You concentrate on doing what you need to do, and I'll take care of the chats.
Okay, sounds good. So I'm sure that I don't need to convince this crew today of why early identification is important, but just some quick prevalence data to touch upon, because all of us as providers are acutely aware of it. We know that about 1 in 6 children in the US has a developmental disability of any type. And then autism, the most recent estimates are about 1 in 36 children has a diagnosis of autism. So it's certainly highly prevalent in the United States. But we also know that the majority of children with developmental differences are not identified really early. The majority are identified, they enter kindergarten without having that developmental difference, whatever it is identified. Specific to me and to us here today on the call, we know that autism can reliably be identified, as early as 18, sometimes even 12 months of age. However, the average age of diagnosis remains around 4 to 5 years old. And of course, certain populations face disproportionate delays in access to diagnostic and intervention services. I'll speak a little bit more to that later on in the talk. But this is important because early symptoms of autism specifically can really impact our social development, cognitive development, language development. And so it's very important that we are identifying differences as early as possible so that we can facilitate access to early intervention and prevent the development of further delays or potentially challenging behaviors. There is a lot of evidence for early intervention with children with autism. I'm not going to spend a lot of time going into the specific interventions today, but naturalistic developmental interventions, applied behavior analysis, I'm sure you're all aware of them. Research indicates that intervention beginning before age 3 has a much greater impact on children's outcomes rather than starting after age 5, for example, which is around the average age of diagnosis. Some of the impacts we can see are improved language and motor skills, even improved cognitive skills in this population when it started really early while those kiddos' brains are still so plastic. I love saying that. My kids hate it when I say that their brains are plastic right now, but this is how do we identify kiddos early, right? So the American Academy of Pediatrics puts out some guidelines for ongoing universal developmental surveillance and screening. Developmental surveillance and developmental monitoring differs slightly from screening. Developmental monitoring is something that is really meant to be an ongoing process in partnership with the family and their primary care provider, where they have conversations as early as 2 months old, talking regularly about typical development, any family observations of differences in their child's development. And there are a bunch of really cool tools out there right now that are used to help, families who, especially if this is your first child, I remember having absolutely no idea what typical child development looked like. And of course, we even know that within the realm of typical development, it can vary so widely. One of the signs, if you're not familiar with Learn the Signs, Act Early from the CDC, it's a wonderful developmental monitoring tool that's available online, and they have an app as well. And they just do a great job giving visuals and guidance to families on typical developmental milestones from 2 months old all the way up to 5 years old. And so that can be a really great tool for parents to just be checking in as their child grows up and be able to, whenever concerns are identified, have a conversation right away with their pediatrician. Screening, of course, is a little bit different. It's a more formal process. Again, it's universal, so every child should be screened for both general development across domains, as well as autism-specific screening using validated tools. Developmental screening, like the ASQ, is a really popular tool that takes place around 9, 18, and 30 months of age. And then autism-specific screening occurs, or should occur, at the ages of 18 and 24 months. This is the process that how it should typically go, right? And I'll talk a little bit about some barriers that might happen even early in this identification process in just a second. But first, let's just talk with autism about what we're looking for when we see developmental differences, because of course, with autism, it's not just experiencing delays in typical development, right? There's often the presence or absence of really specific social communication, social interaction differences that are occurring really early in childhood that we want to be aware of and we want to look for. So as diagnosing providers, we determine if a child meets criteria for autism using that it's a behavioral diagnosis that is made with guidance from the Diagnostic and Statistical Manual of Mental Disorders, or the DSM, just in the 5th edition right now. And in order to meet medical criteria for an autism diagnosis, really what we're told is that a child or a person has to have deficits in two core areas, social communication and social interaction, and then also has to have the presence of restricted, repetitive, and stereotyped patterns of behaviors, interests, and activities, which is a mouthful. And then they have to, have a certain number and constellation of symptoms falling within that criteria that have been present since very early in their childhood, cause clinically significant impairment in their functioning in one or more areas, and can't be explained by another difference, such as an intellectual disability. So I don't know how many of you are familiar with the DSM or who have read this criteria, but at first blush, when you're looking through, the criteria doesn't immediately translate to little people, to really teeny tiny toddlers. But we know we can identify autism in that population. So a lot of really smart people have been doing some really good work to try to take those diagnostic criteria and terms that we don't often use to describe our interactions with toddlers, like social emotional reciprocity, for example, and translate that into behaviors and terms that make sense to parents and just make sense in general when talking about toddlers. And one of the groups that I think has done a really good job with taking the behaviors consistent with autism and translating it into language that parents can understand is FSU, Florida State University, led by Amy Weatherby. They have a project called the First Words Project, and they've put out a lot of really wonderful lookbooks and videos and tools to help parents start to identify the signs of autism really early in their child's development. And they've developed a list called 16 signs of autism by 16 months. And I just like the symmetry of that. And so I'm going to go through some of those today and show you a really short clip of how some of those symptoms or differences might present in really early childhood. Tim, are we doing okay on time so far? Okay, I'm
We're
going to.
about 20, yep, we're about 20 after 9, so you got about 25 minutes to go. You're doing great, Lily.
Oh, thanks, Tim. I really like the positive reinforcement.
You are.
Okay.
This is fantastic.
So 16 signs of autism by 16 months. So um, I'm going to put out a couple of them right here and then talk about how we think about this. So these behaviors right here kind of map onto our diagnostic criteria of delays or deficits in social emotional reciprocity, right? So the ability to really kind of hold an interaction with a toddler and go back and forth with them. So is it hard to get your baby to look at you? Are they sharing enjoyment with you? Do they share their interests with you? Do they respond when you call their name? Um, Even with just these descriptions, I find it can be difficult for parents to conceptualize that. So when I ask about these behaviors with parents, a lot of times I try to use phrases like, how does he respond when you try to start a game of peekaboo with your baby? Or do they look at you? How do they respond when you give them praise or really positive attention? Does your baby want you to be excited with them when they're really excited about a new object or something that they see? Do they bring you things or show you things even when they don't need help? So trying to give really specific examples of some spontaneous behaviors that often occur in typically developing young children, right? To see if we're experiencing some of those differences in that social emotional reciprocity there. Another thing that we're looking for are differences or delays in nonverbal communication behavior, right? So what does that look like in toddlers who often do not have speech or language, or if they do, it's often delayed, right? So We're asking about things like their gestures. Do they point to show you things that are really exciting or interesting, or to request? Do they wave or reach even when you don't prompt them to do that? How do they ask for help? Do they take you by the hand or put your hand on things in order to access help? Those are some things that we see often. It's my eye contact isn't on here, but when I do, of course, a lot of people think about eye contact with little babies. And it's so funny when I was just starting out, I would ask families about eye contact with their babies a lot. And people would look at me like I was crazy because I think it's just something that you don't often ask about eye contact with little children. And so we try to phrase it in terms such as like, is it hard to get your baby to look at you? Or when you're singing or talking with your baby, are they looking in your face or looking at your eyes? Um, Another thing, kind of moving into the differences in social interaction, we ask a lot about play skills because that's of course impacted in children with autism. So we ask how easy is it for your child to imitate you? Can they do it without a lot of prompting on your part? Are they doing any pretend play yet? Has that started at all? Or imaginative games with other people? Um, Some of the more visible symptoms or differences in autism are the presence of these repetitive or restricted patterns of interests and behaviors. So in little children, what we're asking for is, you know, do the kiddos seem like they're much more interested or focused on playing with objects than interested in other people? Or when they're playing with objects, is it hard for them to shift their focus from the object to the adult? Um, do they have any particular or repetitive ways of moving their fingers or hands or bodies? Any repetitive or unusual movements behaviors that they do with toys or objects? Repetitive lining up, putting things in and out of containers, things like that. Um, and then, of course, trying to understand any insistence upon sameness. So, do they develop certain rituals either within play or just within the context of their day that is really difficult for them to be flexible with or shift away from? Um, when I'm asking about these, we call them RRBs, the restricted and repetitive interests and behaviors. When I'm asking about these, I really try to stress to parents that, at any time, any child can display these behaviors. It is not uncommon for young toddlers to line up their toys. Um, However, what we're looking for is how frequently this is happening, the intensity of the behavior, and kind of are they able to shift away from it and engage with toys or objects in different ways, or engage even with different objects and toys. Um, Excessive interest in particular objects or activities. Again, we've all met toddlers who are fascinated by things like fire trucks or dinosaurs, right? But does the interest extend beyond what we would expect for a typical child? Is the focus and intensity so much so that transitioning away is very difficult, or they're unable to play with other objects? An interest or focus on unusual objects or activities, things that are not toys or you wouldn't necessarily expect toddlers to be interested in. Of course, we look for unusual sensory responses, either extreme sensory sensitivity or sensory seeking behavior, and in any form that might appear in. So we spend a lot of time asking about those different behaviors, and I'm happy to kind of speak more about it, but um, those are the behaviors that we're most often asking about and looking for in toddlers. We have the time, I think we do. I'm going to quickly show you this brief less than 2-minute video that again was put out by the First Words Project to show some differences with typical development and a child with autism in those early years and see kind of the differences there. Let me know if you have difficulty hearing it.
Children with autism have significant impairments in social interaction
We're
and
hearing it, but we are not
communication.
seeing it
It
this
is
time.
this, in combination.
You're not seeing it?
Correct.
Okay, let's see why that is happening.
It's because of the snow.
I'm sure it's because of the snow. Let me try one more time. I have it optimized for video sharing. Let's see if this.
That's looking better. Thank
Children
you.
with autism have significant impairments in social interaction and communication. It is this, in combination with the presence of repetitive behaviors or unusual interests, that should signal concern to a trained observer. Think about how typically developing children naturally show a strong interest in interacting, communicating, and sharing their ideas with others, and easily shift their attention between people and objects.
You want me to blow bubbles? Yeah. Can I have the cup? Where's the cup?
Typically developing children listen eagerly to speech and try to figure out what you mean from gestures and other social cues, even before they understand the meaning of words.
Bottle, thank you. Can I have this?
Children with autism have a core deficit in social attention. This core deficit impacts learning and has a cascading effect on brain development.
Get them open. Bubbles. You want more bubbles?
Autism interferes with a child's ability to listen to speech, to notice gestures, to look at faces, and to pay attention to what is important in the learning environment. Autism impacts the ability to learn from people.
Where's the bottle? We're going to say bye-bye to some of these things. Bye-bye, cup.
These developmental consequences are cumulative and can lead to pervasive deficits and extremely challenging behaviors if they're not caught early.
I'm going to give you some and you can just...
Be back to my screen.
We have a black screen, Lily.
You know, a black screen. Of course. Let's try this one time. Okay. How's that?
We're in the presenter view. If you can switch the display settings.
Ooh. Did that not work?
It did not.
Let's see. It's not letting me. Let's see. Try to show a video.
It is always hit and miss
I
with
know.
videos.
What are we seeing now?
Presenter view.
Okay, I'm trying the.
There you go. Everything's good to go, and we are at 9:31.
Great, thanks. Okay, so this is so that I think that video does just a really nice job of showing kind of some of the, I think videos in general just do a great job of taking some of the language we use to identify early signs of autism in young children and really just showing how it can present and how it differs from typical child development, even in things like sharing attention, requesting, things like that, how there's so much at work in terms of social communication, both nonverbal and verbal behavior, right? That we don't even notice with typical development. But then when you see the differences, it just becomes much more obvious. So this is a visual just that shows with the process of early identification, I think it just does a nice way of showing the pathways from monitoring and surveillance to use of formalized screening tools and then referral, right? And referrals often involve kind of two pathways that diverge. We have kind of a referrals to someone like myself, to a tertiary care center, often to do a developmental evaluation and potentially render a formal diagnosis of autism. And from there, further referrals to necessary speech therapy or other services you might access within the medical system. And then, of course, there's referrals to other services and supports that Erin will speak more to, but to our birth to 3 system or special education system to determine eligibility for specific services that they might access through the state. So I really like this visual because I think it just is a really clear depiction of what often happens with, I'm going to kind of shift now into talking about some barriers to care that we experience. So, of course, this shows here a family expresses concern, wanting to, or a positive screen occurs, and then the family is routed to a referral, but oftentimes that means they're placed on a list and must wait a really long time to access services. When they are actually placed on a list for an evaluation, because of course barriers can occur even earlier than that as well. But let's talk about some of the barriers that can occur first at this level of screening. So even though the AAP recommends universal screening for all children at those designated time points, it doesn't always happen that way. Spoiler alert. A lot of the barriers to screening within primary care are resource driven. So for a lot of the screenings, there are time intensive trainings that the providers have to undergo in order to be able to successfully move through the screenings. The screeners themselves are expensive, which can be prohibitive, especially for some smaller, more rural clinics. Of course, primary care providers are incredibly busy, and screeners take time to administer and even more time to follow up on or talk to the family about if there is a concern identified on a screener. Many providers are not trained in their medical training to talk to families about developmental concerns, specifically autism. That's a lot of the work that I've been a part of, is kind of learning those barriers that just within the trying to teach medical residents and even medical students how to think about, identify, and talk about autism at earlier ages. In recent research that we've done, we've seen that a lot of providers, especially in rural areas, are unwilling to screen, even if they have concerns, because they believe that if it was a positive screen, the family wouldn't have anywhere to go. They would not be able to access because of either barriers at the systems level or barriers at the level of the individual family. They wouldn't be able to access diagnostic services, or there are no treatment options within their area. So why diagnose or why put them through that if they're not going to be able to access anything? And then we also know at the family level, there are a lot of variables like parent education or language spoken in the home that's going to impact whether or not they receive screening, or whether or not screening is going to accurately pick up on concerns. We know one of the most common screeners used in primary care is the MCHAT RF, and not sure, the modified checklist for autism. And we know that the MCHAT just does not work as well for families from racial and ethnic minority groups, or families of children living in poverty, or families who speak languages other than English. So that's not great. So of course, there have been some efforts to work to address those barriers, and I'll touch on that a little bit later, but certainly barriers are occurring at the level of the screen. And then, of course, there are barriers occurring at the level of the diagnostic assessment. So we know in Wisconsin, 1 in 53 children met criteria for autism in recent years. And again, majority of those children, slight majority, did not have a full evaluation before 3. And the median age of diagnosis was at kind of that national average, a little over 4.5. And sadly, we know just that probably related to these differences and disparities in screening, we know that children from racial and ethnic minority groups are significantly more likely to access diagnostic assessment and treatment services later than white children, even though the actual prevalence is not different across racial and ethnic groups. So disparities occurring multiple places. There are a lot of barriers to accessing diagnostic and treatment services that have been identified and explored in the research. A big one nationally is geography, right? Is a huge barrier, especially, for families who might have difficulties with transportation or who are unable to take a day off work to drive 2 to 3 hours to a tertiary care center to have a diagnostic assessment. I mean, I included here, Wisconsin has a huge rural population, right? But a lot of the medical centers where they're doing the majority of these autism evaluations are occurring, of course, in the most heavily populated areas, Madison, Milwaukee, St. Paul. And so families are having to drive very far distances in order to actually get a diagnostic appointment. There are also a limited number of trained providers who are able to do these diagnostic assessment services and provide this specialized treatment. But also, we know that we're really limited by the diagnostic tools that we use, both screening tools and assessment tools. We have tests that are very expensive and protected by intellectual property. They are very long, and they are often not designed for or have been normed, validated for every population or setting in which we're being asked to evaluate. This is not all of the barriers, certainly, but these are some of the biggest ones that we've been working to address here at the clinic, and we've seen a lot of research starting to work to try to identify strategies to address some of these barriers to care. Some of them I'll just touch upon briefly that we're trying here at the clinic. I have a lot of my research is in teleassessment, and with some colleagues at Vanderbilt, where I was previously, we developed a teleassessment tool for toddlers, understanding that geography is a huge barrier to care, especially for rural families. We developed a tool called the Tele-ASD Peds, or TAP, through which a trained provider could zoom in to a home and coach parents through a series of activities intended to elicit these signs of autism in really young children using materials that are just freely available in the home. So it eliminates kind of the need for really expensive proprietary tools, reduced burden of training, and hopefully reducing some of those barriers for families where they don't have to leave their home. They can do everything right there.
You're under 5 minutes, Lily.
Yep, and this is my last slide. Thanks, Tim. Another big area where we're trying to focus our supports is in primary care. So families are often, even families who do have difficulties accessing, or in resource poor areas, difficulties accessing care, many of them do have a primary care provider who they're able to see regularly. And primary care providers, we have good research evidence showing that they can be trained to identify these symptoms of autism in their patient population. But we've been doing a lot of work to understanding the system-wide barriers that they encounter. How can we identify open access tools that we can train pediatricians to implement and score easily within their practice, and then but also give them the confidence in having that discussion with parents and actually providing that diagnosis for those children with really clear presentations who do not need to be routed to specialty care. And then another piece is that, at the Waisman Center, and we're certainly not alone in this, but many tertiary care centers across the country are just facing extensive wait lists. And so wouldn't it be great if we were able to offer some services that did not require a diagnosis in order to start working on some of these social communication and social interaction deficits while they're waiting? So we're going to be implementing a pilot program of Project Impact, which is an evidence-based parent coaching intervention where a provider trains parents to really address communication, play, imitation, all within their home while they're waiting to access diagnostic services. So these are just some of the things that we're working on at the Waisman Center. I'm happy to talk more about them later, and I believe we're doing a Q&A later, but that's all I have for you guys today. Erin and Kellie have a lot more that's going to be helpful, but thanks so much for letting me chat with y'all.
Thank you, Lily. And you're right. We're hoping that at the end of this morning, we're going to be able to have all three of our presenters, 3 or 4 of our presenters together for questions and answers. So really appreciate that. And I believe that the presenters will also be able to share their slides with us, and we'll get those made into a PDF and we'll get those sent out as well. So now we would like to go ahead and take a 5-minute break for all those who need to just step away for a little while. We'll be back in 5 minutes to continue with strategies for addressing those social communication difficulties at home and school. I will be hanging out here, but I'm going to stop the recording.
Hey, Tim.